Kayhan Parsi, and I'm an associate editor for the American Journal of Bioethics and a professor of bioethics at the Neiswanger Institute for Bioethics at Loyola University Chicago Stritch School of Medicine. I want to welcome you all to another A-Job webinar. The title of today's webinar is What are Researcher Obligations When a Survey Reveals a Hotspot of Suicidality? We're fortunate to have an amazing panel to discuss today's topic, three of whom, Crepeau-Hobson, Levinson, and Wynia, are co-authors of the September 2020 A-Job target article, Duties When an Anonymous Student Health Survey Finds a Hotspot of Suicidality. The other co-authors of this target article were Marilyn Coors, Jacqueline Glover, and Daniel Goldberg. Dr. Lee is the author of one of the open peer commentaries in ethics for public health surveillance. Now let me introduce our panelists for today's discussion. Franci Crepeau-Hobson, PhD, is an associate professor and director of clinical training in the school psychology program at the University of Colorado, Denver. She also serves as a consultant to Denver metro area school districts on issues such as social emotional learning, mental health, and crisis intervention. Her area of research specialization includes youth suicide, school safety, and crisis response and intervention. Lisa Lee, PhD Mj MS, is Associate Vice President for Scholarly Integrity and Research Compliance and faculty in the Department of Population Health Sciences at Virginia Tech University. From 2012 to 2017, she served as Executive Director of President Obama's Bioethics Commission. She worked for 14 years at the CDC, where she served as the agency's Assistant Science Officer, Director of the Office of Scientific Integrity, and Chief Science Officer in the Office of Surveillance and Epidemiology. She is an epidemiologist, bioethicist, and ethics educator. Next, we have Arnold Levinson, PhD MJ. He is a professor of community and behavioral health and a member of the University of Colorado Cancer Center. With more than 25 years of experience in public health practice and research, his interests include identifying, understanding, and reducing disparities in tobacco-related risks and behaviors among cultural minorities and people with lower socioeconomic status. And finally, we have Matt Wynia, MD and PH, who is the director of the Center for Bioethics and Humanities at the University of Colorado and president of the American Society for Bioethics and Humanities. His interests include public health ethics, professionalism, codes of ethics, and other forms of professional self-regulation. He has served on numerous committees and panels for the National Academy of Medicine and led the project that resulted in the AMA's 2008 landmark public apology for racial discrimination. So welcome, everyone. And my first question to you all is, what triggered your interest in this topic? Perhaps Dr. Wynia, you want to take that one?
I'd be happy to, although I think Arnold probably has more to say about this, because, and Franci for that matter. The reason this came up is because it happened, right? It was a case. This is a case-based event where the folks involved in the case, which includes Franci and Arnold, were felt like they probably did the right thing, but that they did it on an ad hoc basis. And as a consequence of doing this on an ad hoc basis and without sort of clear guidance from a professional association or a code of ethics that sort of addressed this type of issue very specifically, they brought the issue to our research ethics consultation service. So our center runs a research ethics consultation service, not just for public health activities, but for all kinds of research. And we may end up talking a little bit about the difference between research and surveillance, but I think they brought it to the right crowd, because certainly when they brought this to us, we found it fascinating. And so we spent, Arnold, a year looking into this and trying to find, really discrete, clear guidance that might have guided them along their path, and finding a relative absence of that, we decided we ought to write this up.
Just to back up a little bit, Dr. Levinson, Dr. Crepeau-Hobson, could you just tell us a little bit about what the case was about? What was it that concerned you?
Sure. Well, I'll take a run at that. For those of you who haven't read the journal article, this was a situation in which I had been leading a youth surveillance project for a considerable number of years. And over the years, we had migrated toward providing each one of the schools with a snapshot of its results. We did that for a couple of reasons. One was as essentially an incentive to encourage the schools to participate, because remember, this is a random survey. So we select schools at random. They have no stake in the game to begin with, and they have a lot of good reasons why they might not want to participate. So we tried to sweeten the incentive with an offer of report. And over the years, that was working well. But honestly, by accident, an analyst was going through the report data and was shocked and alarmed to see that one school had 2 to 3 times the rate of suicidality and mental health concerns of the rest of the state. And she literally came into my office in a panic and said, "We have to do something." And I said, "Well, that seems reasonable. I'm not sure what to do." And we ended up calling the principal. The principal actually was not surprised. There had been a suicide in the school that school year. And one of the reasons he had decided to participate was because he wanted to see whether this was a bigger problem, and he wanted some documentation so that he could go to his district and say, "I think we need some resources. I think we need to do something. This is very concerning." So we were gratified and relieved that we had done this. But the more we talked about it, the more concerned we became. We wondered in particular, do we have to follow up with this principal to make sure that he did something? And if he didn't do something, is it on us now? Are we supposed to sound the alarm? And if we are, who do we talk to? So we had all these questions. We went to Dr. Wynia's consulting clinic service, and we're pleased to learn that we were on the right track, but that there wasn't really a lot of information to guide us. And that's when we undertook this large research activity in the literature and came away just about as baffled as we had started, and called on the national organizations that work in this area to do something.
Is there anything else you want to add, Dr. Crepeau-Hobson?
Just that I came on kind of at the back end of this, after this process, after they'd collected these data, and Arnold reached out to me and said, "I hear you know something about suicide in schools." And that was the missing piece in all of this, and how the role of the principal fits within this, and educational ethics and suicide prevention in the school setting, and what does that all look like? So that's where I came in to this project, to provide that perspective.
So the title of today's webinar is "What are Researcher Obligations?" But in your article, you make a distinction between research and surveillance, and the ethical obligations that are attendant to researchers and to people that are doing surveys. And I was wondering if you can help us clarify that distinction, because that may not be very clear to folks listening. What is the difference between surveillance and research?
Well,
Lisa, do you want to?
oh, yeah,
Yeah, I
I'd
think
like to take a
Lisa's the one.
stab at, yeah, no, thank you. I'd like to take a stab at that, because I think that is something that often gets confused in the literature. And the reason it gets confused, I think, is because often people think of public health surveillance as a data collection. And there are many different ways we learn about health. One of the ways is through surveys. Another way is through studies, through research. And another way, among others, is public health surveillance. And public health surveillance, as a person who spent 3 decades or so doing public health surveillance and involved in the ethics of public health surveillance, I think it's important to recognize the difference in the purpose of a data collection that is done through public health surveillance versus one of the other modes of collection. And that is that when we think about research data, we think about collecting data, and the risks that a research participant takes on are risks for other people, for the benefit of other people, not necessarily for themselves. When we think about public health surveillance, it's really the eyes and ears of public health as a field, and we have made a connection with our citizenry that we've made a bargain with them that we will make sure that we have a way to assess the health needs of the population, and that is through public health surveillance. Because public health surveillance, it serves as the eyes and ears of public health, it is incumbent upon a public health department or an agency that conducts this to act on the data that the surveillance system brings to bear. This is different than in a research project where we might publish the information and it might help create generalizable knowledge and create further knowledge. But for public health surveillance, it is a very specific set of activities. It's not just a data collection, but a set of activities that starts with this idea of, if I'm going to collect information about a population, why am I doing it? What am I going to do as a result of the findings? And so when I first read the paper, I thought, well, of course, if this is public health surveillance, of course, the obvious thing is you act on that. And so it really, after reading that and then the collection of the commentaries, it became pretty clear to me that there is a real misunderstanding about what public health surveillance is and how it's different than research, whether that's clinical research or public health research. It's really the diagnostic technique that a public health professional uses, analogous to the diagnostic techniques that a clinician uses for individual patient health. You do an X-ray, you do a laboratory reading, et cetera. For public health, our diagnostic techniques are really the foundation of those are public health surveillance.
Could I add just one thing to that struck me when I was struggling with this because it was a new area to me? It seems to me that research in general, with maybe some exceptions, knows who the participants are and knows who might turn out to have a particular condition that warrants any sort of a follow-up. In our surveillance activities with the schools, we literally have no idea who the kids are who said, I planned to take my own life. And so we really are cut off by at least 1 degree, if not 2 degrees of separation from that person, and we have no way to identify them. That struck me as a particularly challenging ethical concern.
And this is a common ethical concern when we do anonymous surveillance or serial surveillance. It's different when we do case-based surveillance, which is really connected to a name and a person. So there are different ethical considerations about what kind of surveillance system one does. As I said in my commentary, at the start of the HIV epidemic, when we really couldn't do anything for anyone with HIV, and it really didn't help to know, except for the fact that that would help decrease transmission. We did a lot of serial surveys, anonymous serial surveys, just to get a sense of what the heck was going on. But once we knew we could do something for people, then the anonymous survey was no longer the ethical choice. And so this is also something that we have to think about when we plan public health surveillance, which is, what is our purpose here? Is our purpose to find individual students in schools who might be thinking about taking their own life? Or is our purpose here to get a sense of what districts need additional counseling and additional help? And we would pick different methods of public health surveillance based on the kind of question we're asking. And I think that the ethical part of this is, for me, it is incumbent upon a public health surveillance scientist to think about these things ahead of time. This is about planning. It's not just, oh boy, now we don't know who they are and what are we going to do kind of thing. So it's really, it's a process that has to be infused with the ethical lens.
So the Target article cited guidance from a variety of sources. So you looked at public health ethics, research ethics, education ethics. And so my question is, do we need a new field or new subfield of public health surveillance ethics?
Well, as a person who's been doing public health surveillance for many decades, I would say that it, and as I described it, it really serves as kind of the way we diagnose public health problems, that the ethics around public health surveillance is situated quite well in the ethics around public health in general. And I would suggest that if we think about what public health professionals are ethically bound and in many cases legally bound to do, it really can be situated quite well in the existing framework and number of frameworks that guide public health decisions. So I'm not sure that we need to hyper specialize and have something very specific for public health surveillance. That said, I think it's really important for all people who engage across the spectrum of public health surveillance know that they have ethical obligations to plan well, to think about what they're going to do with the information, to plan ahead and think about what the purpose is and what's the best method and that kind of thing. So I think if we can situate it in public health ethics, we've gone a long way in ensuring that the approaches and the follow-up are done ethically.
So your thing is we already have a good foundation in public health ethics.
I think we do, and I think in many ways I feel like, wow, if we weren't, if somebody doing this kind of survey was not already aware of how we do that, then it's really on the surveillance experts to ensure that we get that message out there. So that's why I was so pleased to be able to participate in this webinar, because I do think that there are a number of pretty well accepted guidance documents around what to do with public health surveillance data. And that those aren't available to people involved in surveillance is concerning to me. So I'm glad to have the chance to talk about those.
Can I ask Lisa?
Yeah, go ahead.
I don't mean to take over the role, but you're raising a question whether there's already adequate guidance for the questions that were brought. And I have to say, in looking, I mean, we saw the WHO guidance and so on, and I didn't feel like it answered Arnold's questions with regard to, so what if this principal had said, yeah, thanks, and that was it, right? So what is his responsibility then, or the team's responsibility to the students, to the classroom, to the school, to the parents? Would they be obliged to then take the next step of going to the principal's supervisor to say, so this, in some ways, this case worked out nicely, but it raised these additional questions. And by the way, what's the trigger, right? So here we had a case where not only was there a difference between this school and all the other schools, it was an enormous difference, right? Almost half of the students had significant suicidal ideation. 20% of the female students in this school had tried to commit suicide, had an actual suicide attempt. So it was a huge thing. What if it had been, a 10% incremental increased risk? Do they have an obligation to call that out? And that was where we felt like, we looked at the guidance and it was kind of nebulous, and we looked at things like the Tarasov rule and return of research results, and nothing quite got us to where we thought we needed to go.
Matt, I think that's an excellent question. I don't think we will ever find a recipe for this particular case, right? But I do think that, as I talked about earlier, public health surveillance is done with an a priori objective to do something, to identify, certain people with certain conditions, to identify communities that are at higher risk, and that needs to be outlined before. So ideally, in this situation, we would have known ahead of time, what is this surveillance system for? And if we think, okay, we're asking sensitive questions about sexually transmitted diseases or alcohol use or substance use or suicidality, that has to go into the planning. It shouldn't be that when you get the results, you go, oh my gosh, now what do we do? I mean, you're looking for something that's a public health problem. Before you go in to find it, you got to know what you potentially would do about that. So I would say that if this survey was truly public health surveillance, then there's obviously an obligation to act, because that is, by definition, what public health surveillance is. You have an obligation not only to know what you're going to do, but then to do it. Now, if it's research, there are really different ethical drivers for what I'll call incidental findings in research. Now, if this were a research study and participants knew that they were not going to be directly benefiting from it, but in fact, any risk that the school system was taking on, i.e. finding out information that is concerning, is a risk for others. I mean, it is for the benefit of others, not for them. Then the kind of ethical dimensions about what one does with those incidental findings changes. And I would like to call to people's attention, Obama's Bioethics Commission did a report called Anticipate and Communicate, looking at incidental findings in 3 different contexts: in research, in clinical context, and in direct to consumer contexts. All 3 of those, while the values stay the same, the purpose of those activities are really different. And it's important to recognize when one is going to begin these activities that they recognize what their ethical duties are based on the purpose of those activities. And I would say that public health surveillance is another one of those. And I actually did some work following that, looking at what that means for incidental findings for surveillance. And I'm hard pressed to say we would have incidental findings because we should know ahead of time what it is we're after. We don't always, but when we do find those things in public health surveillance, then our obligation is to act. We don't have that same obligation in terms of research, always.
I'd like to jump in, if I may, as the person with the least experience and background in ethics, but a fairly decent background in public health surveillance. Our survey is very much like the CDC's Youth Risk Behavior Survey, which is done every 2 years in very many schools, all of them randomly chosen. And CDC's protocol does not, in fact, look down to the level of schools. It looks strictly at the state. And the purpose of it is to inform the state health departments of the relative risks of various behaviors among adolescents and to track them over time. So there's the purpose. It raises the question in my mind, based on what you're saying, whether there is an unanswered concern about the fact that the schools randomly chosen and within those schools, the students randomly chosen are simply measurement tools. Because in fact, that's the way we treat them now. When we went to a next step, which by the way, I think is emerging as a fairly, as a best practice, people are understanding you really need to return the results to the school so that the school can do something about them. But that's relatively recent, I have to tell you, that's not a long-standing practice at all. But in any event, in order to return the results, you do have to look at the results, or at least they're going to pass by your desk. You could automate it and never see them. So I don't think actually that there is a recognition when the purpose is to inform the state health department that you may come across not risks that we don't know about. We've explicitly sought to measure those risks, but a hotspot of a risk that in fact was not part of the deal. And we never really, I'm not aware that there are at least plans to work that out in the preparation stage.
And I would say that there are a couple of different ways in which we use surveillance data. And as soon as you signaled earlier that part of the deal was to return, the aggregate results to the schools, I think that does change the tenor of the data collection. And in the case that you've described, really does obligate you to notify. What do? You give the principal this information, and then they have to know what to do with it. So to help them plan something or get in contact with resources for that, I think was the appropriate thing to do for sure. But I think if we're doing a national survey, we don't go back to people who have particularly concerning responses,
Right.
But that's not what we're doing here.
So can I ask this question about duty to warn? Because the article spends a lot of time talking about duty to warn. You spent Dr. Wynia mentioned Tarasov. You talk about the clinician's duty. And what I find really interesting is the differing professional obligations that are present here. So you have clinicians who have a fiduciary obligation to their patients, and they have this duty to warn in certain circumstances. You have researchers who have a certain obligation, Dr. Lee mentioned, to generalizable knowledge. Surveyors, people that are doing surveillance, they're collecting data, but it's not just collecting data. They're doing it with a purpose in mind. And I guess my question is, how do those professional obligations differ with regards to when you discover something that is of concern? For instance, like if you look at, say, a journalist covers stories, and they may see things that are terrible. Do they have a responsibility to intervene? Typically, no. But Dr. Lee, you're saying that people that are doing surveys are doing things with a purpose in mind, and so they do have this ethical obligation to intervene in certain circumstances. Is that what I'm hearing?
Absolutely. For public health, I think that public health surveillance is a process by which the circle is closed, so to speak, when intervention occurs. And that intervention could be a policy change or a policy decision. That intervention could be something very specific to a community or to a particular subpopulation in the community. It just really depends on what's going on. But I think you've articulated it quite well, that we have the purpose of what we're doing comes with different professional obligations. And I think recognizing that is really important. It doesn't always fit into a tidy box. And I think this is a great case because we don't have only, just this is pure public health surveillance and we know what to do as a result of that. It's been called research, it's been called health survey, it's been called a bunch of different things. And we probably want it to do a lot more work than it can do, but I think you're right on with the different obligations, and that determines what we ought to do as a result.
We could expand to the sort of what if. So what if we did have individually identifiable information about specific people who said, I have a plan to commit suicide, which there was a fair number of such individuals in this survey sample. Now, we can't do that, but one can easily imagine a circumstance where either a public health system or a private actor, Google, for example, or Facebook, had access to that information. And while the intent for gathering the information may have been one thing, if you are in possession of actionable information about a specific person who is at risk or who poses a threat to others, I think it does raise questions, unresolved, probably legal questions about your responsibility, as well as, difficult ethical questions, perhaps about your responsibility to alert someone, either to, the duty to warn type thing, or even a duty to protect others. Right? What if we had a survey that asked, do you have an intent to harm someone else in your life? And we got, an identifiable result back. Even if you did that in a surveillance context, I think you'd be very hard pressed to say that, well, I was doing this with the intent of just looking across the population, not looking at individuals. I'm sorry, once you see that, you are in trouble if you don't do something with that information.
I think you're right on. I think that's absolutely right. And so a great example that I can think about that's very public health surveillance oriented is, back in the day when I was doing HIV surveillance, we would do that in connection with contact tracing. And we had a number of folks who were repeatedly reported as HIV positive individuals who were repeatedly reported as contacts to other people. So we knew that they were, through the surveillance system and the contact tracing system, that they were actually repeatedly exposing and knowingly exposing other people to HIV. And the question was, what do we do about that? Well, we had the information because we were a name-based public health surveillance system for HIV, and we actually did have an ethical obligation to do something about that. partly for the health of the individuals who were being exposed, and partly for our community health, for the general prevalence of HIV in our community. And so I completely agree with you. If we were very interested in not doing that, we would not collect identifiers and know who they were. But that's not the case in this situation. So I agree with you completely. And that's why thinking about this stuff ahead of time matters so much. Because if you do want to be an actor that intervenes on an individual level, then you actually need to know how to get to those individuals. So
I was going to ask a question later, but I think it may be helpful now. There's the concept of total institution that sociologist Irving Goffman developed many years ago, talking about places like schools, prisons that have considerable control over people's lives. And my question to you all is that when you're looking at this kind of surveillance done on students in schools, can you apply this to other kinds of quote unquote total institutions like prisons? And then how would you compare the set of obligations that would be that would emerge if you're not dealing with, say, this kind of total institution? Does that matter at all?
Arnold, you're muted.
See now, sorry. I'd like to make an argument that schools may be, if not a unique setting, a setting from which generalization should be pursued cautiously. And I'd actually like to go back to close to a debate. We're starting into a debate, I think, about what are the responsibilities in this surveillance context. But I think that because, first of all, schools are where virtually all children in the United States show up, with some exceptions, of course, homeschooling. But because it's a virtually universal institution, and because it's not a coercive institution, although we can argue whether our kids want to go to school or not, it therefore plays a public function that is unlike, for example, prisons or other sorts of more elective circumstances like college dormitories or whatever. And so I think for that reason, another reason though is because, and this gets me back to the discussion that I'm still not pleased with or content with. We survey them every 2 years. We simply do that. That's a fact of life. And we have done it historically without attention to this question of what are our obligations to the participants. And I think, again, we've done it because we are seeking to inform the state. This is what has been going on for decades. And I don't think, partly because we haven't examined the question, and partly because we don't have the luxury of knowing who the individuals are, I don't think we've worked out the details of how we should proceed when we do find something. I agree, Dr. Lee, that when we take a look and we see that a school has something, as you say, of course we need to do something. That was our feeling. But then when we looked for all the guidance, we didn't get guidance about who we should talk to, whether we should talk to anyone other than the general principle that you're supposed to do something, and what level of alarm or what particular problems should we be concerned about. We focused on suicide because it jumped right out at us. Should we be concerned if we see a school that has a very high prevalence of illegal drug use? Is that something that we need to see as an imminent danger? And does imminence play a role here? So I still think that the details, the devil really is in the details for those of us who are in the field practicing. So, and when it comes to schools in particular, because they do have a guardian, unlike other institutions where we know we can go to a person whose job is to make sure these kids are okay. I just think they should be treated separately.
I'm in complete agreement with that. I just wish that this were a discussion that would happen prior to the execution of the public health surveillance activity. That's my point.
So can I just add, because I think one of the things that was compelling to me when this case was brought to our consultation service is that these are not risk-free decisions on the part of the surveillance team. When they stick their neck out, in a sense, and contact a specific principal to say your school has a high risk of suicidality, you probably ought to do something about that, is the implication. And now what? Right? So they have now taken on some level of responsibility for not, at least that's the, I think, natural implication, is that, that once they've done this, maybe they're not done with their work yet, or maybe they are, but that guidance wasn't there. So, if there had been CDC guidance on on this healthy student survey that said, if there is a threshold of this, then your responsibility is to contact the principal. Once you have contacted the principal, your job is done because they have the responsibility to care, right? That would have been pretty nice guidance, and would have given them some legal, if not moral, cover for knowing that they had gone as far as they were supposed to go.
I think too, the question of whether we have a duty to look is really completely unanswered. I think, again, we were at the time the exception in producing local reports. We had an accidental look as a result, because we weren't thinking that in some way obligated us to those particular schools. Instead, we thought we were not doing them a favor, doing ourselves a favor and doing them a favor, in the sense that we hope you'll use these data. And by the way, isn't this a good reason why you'd like to participate? Because we know that you've got other busy things in your school and your classroom than our survey. But that raises the question, why doesn't or should CDC obligate every one of its YRBS states to look at the particular schools that they've chosen, and if they see something, say something, and if that's their obligation, what's the threshold? And it really does open this cascade, I think. The other point that I would just like to make is that these are randomly chosen schools. We happen to be increasing our numbers so that these days the successor director of this project is in literally hundreds of schools now, but back then we were in 100 at the most out of 600 high schools. It's just by chance that we happened upon these. Now we get closer to the research subject, I think, sort of obligation, where we've essentially randomly picked some people, and so they're supposed to represent a larger population, but what are our obligations to them? I just think this is a messy area.
Let me take some of the questions that we've been getting in the Q&A. So someone asked, just to reiterate, someone's degree of ethical responsibility depends on how connected you are to the intended population, national compared to local. Is that what you all are saying?
I don't know that that's necessarily what we were saying, but I do think, to both Matt and Arnold's point, that you can't unsee what you have in front of you, right? And so to say that you're local and you've seen the local or the stratified analysis, you can't ignore that. I think that is a fundamental, driver of all public health data collections, which is why in many situations, and one of the foundational values around collecting public health data is don't collect information you can't do anything about. And anything might be, you can't change policy, you can't argue for funding, you can't do it. But if you're going to collect the information, you're obligated to do something with it. And so if, for example, you do a statewide study and you don't identify the school, and you just do a bunch of schools and you just say, these are schools, we don't know where they are, you can't go back and help. But once you do, you've obligated yourself. And I also want to say that I think it's particularly important, as this case shows, that it depends on the problem. I mean, I don't think you'd find a soul who would argue, yeah, well, they're suicidal, what can you do? Like you might if you say, well, yeah, they had, they are hungry, 3 times a week or something like these are really different problems. And we are talking about the most, lethal kind of way to solve problems. And that puts this in I think in a qualitatively different sphere.
So I have a couple questions here about IRB, so let me group them together. So one question is IRB review typical if it's the state public health department doing the surveillance? And then following up, more of a comment than a question. I'm sorry, yeah, so more of a comment. Our IRB insists that whenever questions are asked about suicidality, positive answers trigger display of suicide referral information.
That's very common.
I can speak to the IRB at our institution. Our IRB will no longer allow any sort of contact with students, whether we call it surveillance or research, and whether they consider it exempt or not humans. They will automatically, because their children say, this is a human subject's question, we may give you an exempt protocol, but you have to go through us. And in fact, we did. And I think that's increasingly the rule now. I believe that the standards have been upped in the human subjects language.
I will say the recent change in the common rule that was made in 2017 and implemented in 2019 actually creates a very specific carve out for public health surveillance. And the reason they do that is because of all the things that public health surveillance is, which is it's not research. A lot of people try to say surveillance and research interchangeably. They're really different things. And I think that, we have to be really, that's why I think your question earlier, Kayhan, about the difference between research and surveillance is really important, because most things are not surveillance, even though people like to say that because they think they can get out of the IRB or something like that. But it's really important to be clear about what the purpose of this data collection and data system is, and then to respond accordingly. But there is now a particular carve out for public health surveillance in the common rule.
There was a question specific to you, Dr. Wynia. Describe the relationship of the Research Ethics Consultation Service to the IRB.
Oh yeah. Well, so I just want to I'll
go ahead and
answer
go back
that
to your,
also.
Sure.
But I just want to make sure we're clear. My understanding is that public health surveillance activities do not need to go to an IRB. They sometimes do, because the people carrying it out feel like it's useful to go to an IRB, and it's a nice sort of backstop that you are, carrying out your activity in a way that is attentive to the rights of the individuals and organizations involved. But it's not a legal requirement or a regulatory requirement. It was specifically carved out, and I just want to make sure is that true?
That is true. And that's why recognizing the way that public health surveillance is situated in public health ethics is so important, because I don't want to give the impression that if it's surveillance, woo-hoo, you can do whatever you want. I mean, still we want that carried out in an ethical way. It just is not, it's not required to meet the common rule requirements. It is required to meet ethical expectations, to be sure.
I would like to add, though, that our institution declined. Remember, the state health department contracted with us, and we're in the university, and the university said, as a matter of being our institution, we won't let you go out and do this, even though it's public health surveillance, until you have gone through IRB review.
There's another question here. From a regulatory perspective, it's clear that there's a difference between public health surveillance and research. OHRP guidance defines the difference in terms of the goal of aiding policy formation or decision-making of a public health entity. But ethically, as opposed to a regulatory point of view, is that sufficient to justify such a significant difference in ancillary obligations to participants at risk?
I don't think there are huge differences, actually. I think that as we've said, if a public health surveillance scientist finds a particular person that has particular risk, of course they're obligated to do something about that. And the example of the HIV surveillance situation was one where, no one would imagine to just turn your head and say, well, people keep exposing each other. I mean, we really did use that. So I don't know that there's that big of a difference. I think the key thing about research is that there's not always an obligation. It almost is reversed. There's not always an obligation to disclose research findings to a participant, even their own findings. Sometimes there is, but not always. And we have to think about the purpose of the research is not to take care of individual patients. It's to learn generalizable knowledge. And sometimes you find an incidental finding that is life-threatening or hugely, there's something you can do about it very quickly. And then as a researcher, you think, wow, I should do something, I have an obligation. But generally, that's not the purpose of your activity. And so I think for a public health surveillance system, the purpose of the activity is to create community health and encourage community health. So however we have to do that, we do. That's not the purpose of research, and often that's not what researchers do. So I think it's pretty clear that there's a lot of ethical guidance for public health surveillance. It's not in a federal regulation, and maybe it needs to be more clearly articulated, but very few things actually fit into that specific definition of public health surveillance.
Dr. Wynia, could you go back to that question about how the Ethics Consultation Service works with the IRB?
Yes, and I want to bring Franci in because one of the things Lisa just said just triggered a memory for me about one of the considerations we talked about in the committee was if you were to say that there is a responsibility, as we ultimately kind of did, to go back to the schools and alert them to these things, would that facilitate or hinder participation in the survey to begin with? And it relates a little bit to our earlier conversation, which reminded me of there's sort of a quip from the House of God that if you don't want to find a fever, don't check a temperature.
Well, don't test, right?
Right, exactly. And I think
right,
it is possible, at least this was one of the considerations we had in our conversations about this, that if you were to tell schools in advance, hey, if we see anything, we're going to let you know, that they would say, oh, okay, I'd rather you not include us in this survey, because once you tell me, now I have a responsibility to do something. And as Lisa pointed out, maybe I don't have the resources, the wherewithal to actually address the problem that I think you're likely to show me that I have.
And Matt, I think that goes back to deciding what kind of surveillance you're going to do given the problem. And that, in the commentary I wrote, again, when we started with HIV surveillance, we felt perfectly comfortable ethically with doing the anonymous survey. But once things changed, we said, oh, this is no longer works because we have an ethical obligation now because we can do something about it. And I think if you get in a situation where no schools want to participate and there's no other way to get the information, you might rethink that. I don't know.
Dr. Crepeau-Hobson, did you have something else to add to what Dr. Wynia said?
Yeah, we had quite a few conversations about this. And one of the questions that was brought to me was it, do we need to do more than just sharing the results? Should we highlight this area related to suicidality in this particular school? And I'm like, absolutely, which is what they did. But then the questions around, well, once we've shared this information with the principal, are there additional obligations on the part of the surveyors in terms of, do we go back and make sure they did something with that? No, ball's in the principal's court. And the vast majority of school leaders do want this information. They have an ethical obligation to foster the well-being of the kids in their schools. And they often cannot get additional resources in terms of prevention, intervention, mental health, unless they have the data to show that they need it. And most folks will welcome this information, so they are equipped to go to the powers that be, to go to school boards, to go to the broader community and say, we have a problem here and we need some additional resources. And it can't be all on the shoulders of the schools. We have to bring in the broader community. We have to bring in public health. We have to bring in community mental health. We have to bring in families, because the schools can't do it by themselves. So of course you're going to have individuals who were going to be like, nope, don't want to know, want to bury my head in the sand, because if I have this information, I don't do anything about it. Now I'm negligent. I could be liable, but the vast majority want this information and will use it in a way to support kids.
That's one of the main purposes of using public health surveillance data, is to create the, the data evidence to argue for allocation or appropriation of funds. And so it sounds like that is exactly what you all are thinking.
So, I just wanted to make sure, Matt, did you get a chance to respond to that question?
I feel like I keep finding something else to talk about.
Go ahead.
Yeah. So there is a lot of crosstalk between our COMERB, which is the Colorado Multi-Institutional Review Board. So it's a big set of IRBs for a variety of institutions in Colorado. There's a lot of crosstalk between COMERB and our research ethics committee. I would say sometimes we get research ethics consultation early in the process, even before something has been submitted to the IRB. If someone has a question about, how to frame a protocol, something like that, we'll occasionally get things at the end of the process. I would say that's where this one comes in, where, we didn't realize that this was going to be an ethical issue, and now we're starting to see that it is. And the IRB is not really an ethics committee, as you know. The IRB is primarily, to protect research participants from harm. So these sort of post hoc ethical issues there's not an obvious way to bring those to the IRB even. So the ethics consultation service is an adjunct, I would say, to the IRB process, and has been a valuable adjunct. Several of the cases that have been brought to our research consultation service have ended up in conversations like this one and publications. So I think it's been a very valuable resource for our research community, and I should say for our public health surveillance community.
So I wanted to get to this question, go back to this question of duty to warn, and this question asks, please discern an obligation to warn when respondents' answers are identifiable, which for surveys will not generally be the case, and when not, which is likely to be the case for surveys, especially as there's very likely to be asynchronous lag between data collection and review of collected data, when a risk that may merit an obligation to warn may arise. So that's an interesting question about this gap in time.
Well, I think the anonymous setting or context is the one that we had and the one that still troubles me. I mean, even after listening to this discussion, I find myself as a student health surveillance practitioner feeling as though, sorry, that's our cat, the joys of home work. I find myself feeling as though the questions I had at the beginning are the questions I still have. That is to say, okay, I've taken on the obligation to the schools because I choose to, and it's a choose. I choose to look at their local school data. Now, what are my obligations with respect to which risk, at what level, and what degree of immediacy? I think the questioner's point about the lag is germane here. Most obligations, duty to warn, talk about imminent danger. And in fact, this isn't imminent. And yet, as we've all said, none of us would feel comfortable walking away from a school with astronomical suicidality rates and say, well, I don't know if it's imminent or not, so I don't know if I have a duty or not. But then we go down the level of number of people at risk compared to what, and severity of the threat compared to what. And this is where I still think, and I'd just like to issue this plea once more, the national organizations that look at this stuff really need to help us. Otherwise, I think what I need to do as a practitioner is I need to add a member of the bioethics consulting service to my team as a regular, which isn't a bad idea, by the way. I understand
Good
that.
idea.
And it's a lovely idea. But the fact is, we may not all be able to either have access. Our institution is fortunate to have the service, and not that many do, I don't believe. But also, we may not have the resources to bring another investigator level person on. So while yes, I think that that is a solution, I still think we need some more national guidance at a greater level of detail.
I concur with that entirely. I wish we had more national guidance on this. And I think that, you know, this has been an area at CDC that's been variably attended to and funded, and this meaning public health ethics and what to do in this situation. CDC does have a public health ethics consultation service. This would be something I think that would bring to their attention a chronic condition in terms of our public health surveillance systems. And it would be perfectly reasonable to ask the public health ethics group at CDC to attend to this. Now, they're busy right now and not the most empowered agency at the moment, but at some point, let's hope that they will get their mojo back and be able to work on this. But I agree with you. I think, you know, there has to be at least some explicit parameters so people have some sense of what's going on. Now, as a surveillance scientist, to me, and I, you know, we're working in a state health department, it also, to me, it was just obvious, but that's because it was more of a you know, a professional kind of expectation rather than, so I do think it's worth bringing this to the attention.
This is more of a comment than question. States, it's true the situation here was created by migrating a surveillance project from a survey that represents at the state level to one that represents at the school level. That might have been the trigger for thinking through the implications of school level findings. Another surveillance example, when collecting COVID sero survey, it planned to notify individuals of results and the meaning of those results, even though the individual care was not the intent of that survey.
Sometimes that's the case with public health surveillance. Sometimes we tell people what the results are, but that's not always ethically obligatory.
And then
especially if you can't do anything about it.
Right,
Yeah.
that gets closer to the conversation within research ethics on the return of research results that are you know, found incidentally. The, you know, cases in genomics where you've got a whole genome sequence, and then, you know, 6 months or a year later, or 2 years or 5 years later, you've got now access to information about someone's genetic risk. And do you have the obligation to go contact that person? One of the main reasons we didn't feel like that conversation was directly on point here was because these are anonymous survey data. So we actually can't go and find the specific young woman who said, I tried to commit suicide last week.
But you could go to the school that is having this, and that is an intervention. And that is, I mean, it's the most you can do, which is what you did. And so, I mean, again, the idea, you know, for not having identifiable information might very well have been, we can't go following up individuals, so let's not find out who they are. But we can, in this case, do some more community, and by community, I mean school level interventions, which I think absolutely is an obligation of the work.
Yeah. It does leave, by the way, still unanswered Arnold's question of, you know, I'm going to presume, I haven't actually seen the data, but I'm going to presume that the levels of suicidality in schools follows something like a bell-shaped curve. And this school.
Oh, we lost Matt.
Yeah. Matt froze up.
You were shaking your head, Arnold, but
Well,
it doesn't.
I don't think, I mean, this was such an outlier that I don't know that we'd find a bell curve. And honestly, I haven't looked, but go ahead, Matt. I'm sorry.
Am I back?
You're back now. Yeah, go ahead.
I had you guys the whole time.
Okay.
Oh, I am getting a little notice that says my internet connection is unstable. So apologies if I freeze again. No, I was just, you know, what if there is a bell-shaped curve and this is way out here, presumably there's also someone who's here and someone who's here and someone who's here. And, you know, what's the cutoff for where you say, you know, this one, you really ought to pay attention to? And there probably is a statistical way to look at that, you know, one standard deviation out, that's when we start calling particular attention to these issues. But
except that I suspect when you combine it with the severity of the risk and the immediacy of the risk, it's no longer simple. Now I think you're probably looking at an algorithm. And again, you know, as you said early on, Dr. Lee, there isn't going to be a menu for this. But on the other hand, without guidance, it's impossible for us to know what do we sound the alarm on and what do we not.
Part of it, I think, also has to do with resources, right? I mean, you know, if you have a plethora of resources, you can go, you know, not just one standard deviation, maybe you can go half a standard deviation out, and everybody, you know, but the reality is there are all these constraints in real life that you know, cause us to think thoroughly through what it is we can do. We can't always do what we should do, and those are really tough situations.
This question is about, from the caregiver perspective, what is our responsibility on our clinician surveys when there are higher pockets of suicidal ideation?
I'm not sure I understand the clinician survey, but I would say that if you're a clinician, you have a completely different set of responsibilities than you do if you're a public health surveillance professional or a school, you know, counselor or what. I mean, you have to pay attention to your own profession. I mean, that is, you have a fiduciary obligation to the person sitting across from you or, you know, with you. And so I think they are different. I'm not sure I understand if I answered that, because I'm not sure I understand the question.
So I'm going to go to a couple of the other open peer commentaries and ask some questions from there. So this one was from Navratil et al. They state in their open peer commentary that, quote, given the rates of mental health problems and suicidality in adolescence, we operate under the assumption that all participants are potentially at risk. And so what do you make of that kind of risk assessment, especially in light of the current pandemic?
I would defer to Franci on this. I think from the surveillance perspective, we are measuring in order to find out, have things gotten worse this year compared to last year? If we do go down to the local school level, we're asking, is this school worse off than other schools? But the universal risk among adolescents is something that I think Franci has a great deal of information to share.
Right. And I struggle with this assumption that all participants are at risk or all kids are at risk. Yes, we do have a public health crisis when it comes to youth suicide. We do have high rates of mental health challenges in youth, but not all kids have mental health challenges, and not all kids are at risk for suicide. We know that, you know, if you look at national and state surveillance data, we know that about 17 to 18% of kids will report suicidal ideation in the last 12 months. That's not all kids. But of course, we want to tackle this issue the way we tackle all public health problems, right? We intervene or we operate from a prevention standpoint, primary, secondary, tertiary. We know how to do that when it comes to suicide risk in the schools. We know what works. But I do also want to acknowledge that we're very, very, very worried that we are going to see some significant increases in mental health challenges and suicidality in kids, given the pandemic. Kids are, many kids, we were having this discussion before the webinar, many kids are in remote learning environments. They're not in their brick and mortar schools, which makes prevention and intervention so much more challenging. It makes it significantly more difficult to identify kids who are at risk and at imminent risk. And so, you know, figuring out how we're going to address that is something that we're certainly grappling with in the K-12 environment, and I would think in the broader public health community as well. This pandemic has exacerbated existing mental health challenges and created new ones and made it much more difficult for many children and families to access resources and for us to engage in what we know works in terms of prevention and intervention.
How does suicidal ideation present differently, say, in adolescents compared to, say, adults?
Well, a lot of it, we know that the risk factors are relatively universal. There are some things specific to kids in terms of, academic challenges, parental conflict, relationship conflict, those kinds of things. Kids are much more impulsive, which also makes it a little bit more challenging. And we are typically we identify suicide risk at schools because kids spend so much of their time there. And we have folks who are trained to do that. A lot of times, typically there's warning signs, changes in behavior, changes in academic performance, isolation, a change in personality, those kinds of things. But we also may see those in adults as well.
So going back to the school that was at the heart of this case, the question here is, what were the characteristics of the school or its catchment area that one might think would make it a hotbed of suicidality, and did the school do anything?
To the first question, I don't think the characteristics of the catchment area would have flagged anything. As it turns out, a student had died by suicide in that school, and and the reason we think that there was so much thought about it and copycat behavior there was because, in fact, suicide does tend to occur often in clusters. But I don't think there was anything in the circumstance that would tell us. As far as what was done about it, I can only tell you what the principal said, which was he knew that he was wondering whether there was an issue. He was pleased that we could get the information back to him, and it's why he let his school participate. And he was going to do something about it, including going to the district for resources. We did not follow up. And again, the question, should we have? I'm not sure we should have, but so I can't really fully answer your question.
So again, going back to one of the open peer commentaries, this is by Martinez Martin, stated in that commentary that, quote, in the current pandemic, the potential public health benefit of consumer data could outweigh the privacy concerns, although measures should still be in place to minimize potential harms from the data use. The question is, how so? It's kind of a broader question than the case at hand.
When I read that, Kayhan, what struck me immediately was the recognition that companies are not public health surveillance authorities, and their purpose for collecting and analyzing data is very different than public health. And so, we know that there's a complete mismatch in mission with public health surveillance versus the kind of data collection in the background that companies do. And I don't think we are in a good position to rely on companies to help, well, not to help, but to actually, determine what comes next. I think it can be an important adjunct, an important way to triangulate information, but I would not, I just think the mission mismatch of, profit and information for profit versus something like information for public health intervention is a real mismatch, and we have to be very careful about that. I really feel strongly that we have to acknowledge that those are two really different purposes.
I do see an opportunity or an opening for collaboration personally, but it would require a great deal of upfront negotiation. I think one of the threshold questions for public health would be, how were these data collected, and do the people who gave you these data know that you collected them? And I think before public health could engage, there'd probably need to be some sort of an agreement that everybody whose data has been collected would be notified by the company that this is the case, and that there is, in fact, an interest in a public health partnership in order to protect the public using these data. So I do see that the data are valuable, but I think, as Dr. Lee said, the conditions under which they were collected are so contrary to the obligations that public health has that would have to come first.
I mean, that said, as a source of data for a public health surveillance system, sometimes that works and sometimes that's possible, but a data collection through a private company is not public health surveillance. It could be, again, a source of inputs for a system to then construct other techniques and approaches to collecting and analyzing and using those data.
If we use those data, are we obligated to address the fact that they were collected from our perspective unethically if the people were not notified they were collected?
I think the argument would be everybody's notified. Everybody knows that your data are collected every time you hop on the web and anytime you do anything. I mean, not, you know, any free app is not free. It's actually you're paying for it with your information. So I don't think that, I mean, I'm not a lawyer, but I would suggest that perhaps a company would say, well, we inform people.
Yeah.
So we only have a few minutes left, and I'd like to go back to the one observation that I picked up on, and I think Dr. Lee talked about this, that if you're a surveyor and you're doing surveillance, if you really can't act on troublesome information, you really shouldn't be getting the data to begin with. And so does that have a chilling effect on the kind of data collection and surveillance that these professionals are engaging in? What are the ramifications of that kind of implication?
Well, I will say that one of the major purposes of public health surveillance data is to argue for appropriation and allocation of resources. And this is in many ways was one of the reasons we did the HIV serial surveys in the beginning of the HIV epidemic, because we had no idea what we were dealing with. People were infectious but not symptomatic. And so in order for us to anticipate what we needed, this was the kind of surveillance we thought would be the best that we could do. So, and it was persuasive and helpful, and it really changed the landscape of funding for public health funding for HIV. That is a legitimate and important purpose of public health surveillance. So I'm not saying just close your eyes because we don't have the resources. I'm saying that one of the ways to get resources might be to actually do that, but thinking through carefully the level at which you're going to have identifiers, what your obligations are a priori is really an important thing to think through. The answers are not easy, and not all health departments have, well, no health departments have an excess pile of money in the back that they're going to be able to throw at new questions, or new problems, but they will use the data for advocating for different funding mechanisms for the need. So I don't think it's a matter of closing your eyes. I think it's a matter of thinking through how you're going to use the data.
I would add that I do think there is a potential chilling effect at both the school level and the surveillance level. I do think that our choice to look at the local level opened a Pandora's box for us that we weren't aware we were going to open up, because it wasn't apparent what that might mean. And I do think that Franci alluded to this, and we thought about it as well, and Matt did too. Schools that are told in advance that we're going to be collecting data about the risks in your school, we're going to tell you all about it, and if we see anything concerning, which I put in air quotes because we don't know what's going to concern us in advance without the criteria, we're going to have to tell you that you have something concerning in your school. I do think that even though, yes, schools want to know this, there's also the practicality of dealing with an optional activity, a survey, which doesn't compete well with academics, doesn't compete well with parent priorities, et cetera. So that, again, I just repeat my soapbox message. I think we need some national guidance.
Well, I think we'll leave it there. I want to just thank you all for a really interesting discussion about this topic, about what are our obligations when a survey reveals a hotspot of suicidality at a school. And thank you all for joining us today for your questions and comments. This is being recorded and will be made available later. So again, thanks everyone.
Thanks
Thank
again.
you all for a great case.
Yeah.
Take care.
Thanks, Lisa.
Bye-bye.